Hi, I'm Lynn Erdman. I'm the Executive Director here at the Pink House, and we are thrilled with our guest speaker tonight, Dr. Kim Lyerly from Duke University. And Dr. Lyerly holds the George Barth Geller Chair of Cancer Research at Duke. He's also a professor of surgery, pathology, and immunology at Duke, and he has been named by his peers as one of North Carolina's most outstanding clinical physicians. Dr. Lyerly was appointed to the National Cancer Advisory Board by President George Bush, and served on several committees there, and even as chair of one of the cancer subcommittee. He's been actively involved in global cancer research for a number of years, and he has done cancer research and cancer immunotherapy, but also in cancer genomics. And he has worked in China, India, and he's also worked in Singapore and Pakistan. He currently leads the U.S. Food and Drug Administration committee directed to accelerating entry in the markets for cancer treatment in the United States, and also works globally on getting entry of new drugs into the cancer market in various countries. So we are indeed thrilled. And what he's going to talk about tonight is some of the cancer research that is being done at Duke related to the breast cancer vaccine. I will tell you that he has been terrific to work with. The first time we did a Zoom call to talk about this program, he was actually sitting at the Department of Motor Vehicles in Raleigh, North Carolina, waiting for his son to try out for his driver's license. So he is more than accommodating, and thank you so much for sharing your expertise with us tonight. And Dr. Lyerly, I'll turn it over to you. Thank you.
Thanks, Lynn, and welcome to everyone. I appreciate everyone's being here and their interest and the very thoughtful invitation to participate in this call. Again, I think the world has led us all to Zoom, so we are getting more experience in this, but it's kind of fun to engage and participate in ways that we wouldn't have thought possible, a year ago. I would like to remind you, though, that I'm able to see you as well as you're able to see me. So I also have your names listed. So I know that Beth Harrelson has a nice bottle of wine behind her. So every time I drive with my son, I keep thinking about that. Keep thinking about that bottle of wine, Beth. So I'll have to remind myself about that. So anyway, I'm going to go ahead and share my screen and start with some slides. And I have about 15 slides, and I wanted to make sure there's plenty of time for discussion and questions. So I'm very happy to have questions, while we're talking or at the end. And again, appreciate any comments that you will make. Now, Lynn asked me to talk about breast cancer with a specific focus on breast cancer vaccines. And I thought that was interesting because certainly as of today, there really aren't any breast cancer vaccines. And many people might wonder, why are we thinking about breast cancer vaccines, and what does that really mean? We've heard about the COVID vaccine and of course, the flu vaccine and other types of vaccines. What do we mean by a breast cancer vaccine, and what can we expect, and why are we bringing it up now? So what I wanted to do is just sort of walk through why the science today is so encouraging, and the opportunities not only to think about a breast cancer vaccine, but also to think about how our immune systems, or our own bodies, fight off cancer. Because although this might have been something that certain individuals might have an interest in, we've had a research lab for many years focusing on this. By and large, most physicians, probably up until about 10 years ago, were probably somewhat dismissive of the idea that your body could fight off cancer, and it might fight off a cold or the flu, but not cancer was too tough for your immune system, and it was chemotherapy and radiotherapy and surgery. That was all there was. And I think they're really rethinking that in light of certain new scientific advances. So how do cancer vaccines work? What is the idea of a cancer vaccine? If you have a virus that's going to attack you, you understand that a vaccine prevents the virus from coming in and infecting you. But if you have a cancer, how would the cancer vaccine work? Well, it turns out that the way a cancer vaccine works is the genetics of a cell actually defines a little identity tags on the cell. I used to tell folks they would be like a social security number on every cell. Now I can tell people it's like an internet address or your email address. And each one is unique. You can type in somebody's email address anywhere in the world, it'll find them. And it turns out that the cells process the genetic information inside of itself, and it constantly displays these email addresses. And your body recognizes these email addresses and says, oh, that's the email address for the Pink House or the Charlotte, Chamber of Commerce or whatever, and it says that's a friend, I'm not going to attack that. But if it turns out that there's a genetic change in the cancer cell, and again, you could imagine a misspelling of your email address or the wrong letter put in, oddly enough, even the single letter change in your email address is recognized immediately as foreign, and the body begins to attack that as abnormal. And the fundamental basis of this has led to, 2 or 3 Nobel Prizes over the last 10 or 15 years. And most people understand this now, and it was, generally accepted. Well, as I mentioned, if you have these aberrant email addresses or zip codes on cells in your body, why doesn't your body attack it? Why do you ever get cancer in the first place? Well, it turns out that if you just have these email addresses that are aberrant or these abnormal zip codes or social security numbers, they actually don't stimulate your immune system because your immune system is kind of primed not to attack you all the time. So your body has to be somewhat amped up to begin an attack. You might have some friends who have autoimmune disease or skin diseases. When they get a scratch or they're in the woods and they get a bite or something, then that can really trigger a lot of inflammation on their skin, but otherwise their skin is perfectly normal. So it turns out, again, the number of Nobel Prizes were awarded for an understanding that you have to, when I use the term, light the fire of anti-tumor immunity. And again, why do you have to light the fire? Anybody who started a campfire or, a barbecue or a fire in their fireplace, if you just have a bunch of logs or a bag of charcoal in your fireplace, it doesn't light up. I mean, it doesn't do anything. And so you have to have a trigger, a stimulus to start the immune response. And once that immune response is started, then it quickly begins to expand and can be, quite destructive against tumor cells. So the idea of designing vaccines that are exquisite in starting the fire has been the subject of research for many years. And again, one of the examples would be that even a COVID vaccine, rather than taking 10 years to develop, was developed within a matter of months because there's been a lot of science in how to stimulate the immune system. Well, again, the questions most people might ask is, well, if you know that cancer cells have these genetic changes and you know how to trigger an immune response, what is it that has prevented a breast cancer vaccine or immune therapies from working? And that leads to the final probable secret in the secret sauce of immune therapy. It turns out that your bodies are programmed to not respond in a sustained aggressive fashion. And as you might imagine, if you have a flu, you have a severe fever, you feel terrible for a while, but after 3 to 5 days, you might start recovering and your fever is reduced and you're coughing up stuff that looks terrible, but you're on the mend. And it turns out what people used to think is that your immune system would just get turned on and then sort of exhaust itself. and then you would recover. But it turns out that there are active mechanisms in which if your immune system gets turned on, your body actually actively turns it off. And the way it works against the flu or the measles or a bacterial infection is that you get this immune system that gets turned on, it fights off the bacteria or the virus, and then it gets actively turned off. But the cancer cells, if they persist for months or years, which is often what they do, they sort of take over this system, this braking system that's called the immune checkpoint system, and it actually slows down and stops the immune system from fighting the cancer. And this recognition in therapies that block these immune checkpoints, that's led to the dramatic new medicines to fight lung cancer and skin cancer like melanoma and bladder cancer called immune checkpoint blockade or immune blockade, which again led to the Nobel Prize being awarded in medicine a couple of years ago for this. And this is something you'll see in the, if you read the New Yorker or Newsweek, you'll see an ad for, we have a way to treat lung cancer now without even using any chemotherapy. And it's the only therapy that's ever shown to extend the lives of people with terminal lung cancer. And this is this new form of therapy called immune checkpoint blockade. So, in lung cancer and skin cancer, it seems to work extremely well for a select number of patients. In breast cancer, it's not working as well as we might expect, but again, we can chat a little bit about that. So what about vaccines? How does all this knowledge about the immune system inform us about the possibility of creating a vaccine? Well, one thing that we can do is we can look at the successes in breast cancer, and one of them has been in targeting a protein on breast cancers called HER2, or the human epidermal growth factor type 2. Now, about 20 years ago, 25 years ago, people noted this protein was on breast cancer cells, and if you had this protein on your breast cancer cells, you were more likely to die of breast cancer. And it turns out that antibodies were generated, and people received these antibodies. They're called Herceptin or trastuzumab and so forth, and they've proven to be quite effective in preventing the progression of breast cancer to be as fast as it needs to be. Now, again, we thought this was an interesting opportunity. What about a vaccine that might prevent breast cancer that also targets something like HER2/neu? Well, it turns out that you, in fact, can generate a type of vaccine that would prevent a mouse that is genetically engineered to get breast cancer from getting breast cancer. So this is an experiment that was recently published from our laboratory group, where we used a variety of cancer vaccines. One of them shown, it's called the HER2 Delta 16 vaccine. And if we immunize animals with this, the mice don't get breast cancer. And the other animals that are immunized with different forms or controls, they're like a flu vaccine or another form of vaccine that should be irrelevant, they'll all progress and develop breast cancer. So quite interesting. We also know that there are other types of animal models.
Check the laundry basket.
Can also develop.
Practice tonight or something.
Can also develop cancers, and this is another example where we see
practice? 6?
A dramatic reduction
Feel
in
around
breast
at the
cancer.
very bottom, or go dump everything on my bed.
I'm hearing a little something, but I have 5 kids, and I know they're not any of mine, so it doesn't matter to me. I'm pretty happy with it, so I'm okay. But anyway, this is again an illustration that for many people working in the laboratory, what we do is we try and demonstrate really profound effects. And again, this case where we see a very, very dramatic reduction in breast cancer progression or initiation. But then what we do, and again, this is the advantage of having these large medical centers really next to universities, like in Charlotte and in Chapel Hill and so forth. we took a formulation of this vaccine very similar to the one that was working so effectively in the mice, and we began to test a vaccine in people. And this vaccine was shown to trigger exactly the kind of immune response that we saw in animals. And on this right side of your screen, you see that a number of patients who received this vaccine, they all had metastatic breast cancer. They all had HER2 positive breast cancer that was progressing on conventional therapy. But most of the women who received this vaccine did get an anti-HER2 immune response, and that immune response really seemed to prolong their survival. Now, these are very early studies. We only can immunize probably a couple dozen women in studies of this size because they're done through the university. But that promise allows us to partner with others to try to extend these types of studies and try to create an even better or improved strategy to fight breast cancer. So one example would be looking at the immune response, and as I said, these immune cells, these T cells, and what their potential role could be. When we've had women that have had metastatic breast cancer or advanced breast cancer, perhaps 10 positive lymph nodes, after their lymph node dissection, we did a vaccine study about 20 years ago, and we immunized women. It turns out that all the women who were immunized at Duke are still alive. And we asked them to come back and allow us to draw blood from them. And on the bottom part of your screen, you can see that we can identify these HER2-specific killer T cells that we think are in the circulation, providing that long-term protection so people don't continue to progress. And again, on the top, you can see the 100% of these women are still alive. Again, it's a university-based study, so it's not thousands of patients, and we can't draw the same kinds of conclusions that big companies can draw. But we think the fact that we had nobody die after 20 years with metastatic breast cancer, we know that many people are really struck by that as being not typical of what you might expect. So one of the questions would be, if you have the presence of these killer T cells that are induced by vaccines, but you have a lot of cancer, which is the problem for most people, a vaccine by itself may or may not have the best effect. And what we've tried to do is to marry the use of these vaccines in this setting. And this is an example, again, from our laboratory research that's been published, that if you actually include a vaccine with these immune checkpoints that don't appear to work too well by themselves in breast cancer, this combination of a vaccine plus immune checkpoint blockade looks, quite promising. And you can see on the top line, the mice that are surviving for 6 months or so are really those that are treated with a vaccine plus immune checkpoint blockade. And this data, along with our human data that was published, led to a sufficient amount of enthusiasm that one of the major pharmaceutical companies, Merck, asked us to conduct a study in which we would immunize women who had advanced breast cancer and were progressing on their conventional therapy. And these women would receive the vaccine, and then they would receive the vaccine plus immune checkpoint blockade. And the idea would be, could we see the same results in people that were receiving this vaccine with immune checkpoints as we saw in our preclinical studies? Again, the dramatic improvement in those people really who don't have any choices or any options, and again are failing to respond, or tumors are failing to respond to conventional immune therapies or anti-HER2 based therapies. So we do have the study open at Duke, and we are trying to recruit patients, and we will have other physicians who've tried to open the study at their institution. We have treated one patient so far at Duke, and they had a tumor that persisted following their conventional therapy. They went on to our study and got vaccinated and got the full treatment of vaccine plus immune checkpoint blockade. And we were pleased that just like in our animal studies, our preclinical studies, the tumors really completely lost all of the tumor cells within them. So they had almost like a scar tissue without any tumor cells left in it. And again, we were pleased because as you can imagine, having a vaccine is really much different than undergoing the typical type of chemotherapy with the side effects or toxicities associated with that. So we're very, very hopeful that these types of studies will inform us on how to continue to improve, this type of therapy. So in my last sort of a few minutes, I wanted to spend some more time talking about the idea of vaccines per se, in the more classical sense, what could we use a vaccine for? And I want to acknowledge, and I know that many people believe this, that vaccines are really quite effective in the prevention of disease. And, there are vaccines that are thought to prevent cancer now, and those include the human papillomavirus vaccine and the hepatitis B vaccine. Nothing really quite so dramatic in preventing breast cancer. But I also want to point out that as we talked earlier, the genetic changes that occur in breast cancer might be predictable enough for us to intervene. And so the idea that we could prevent someone who without breast cancer from developing breast cancer, that's a long way off. And again, of course, we're hoping that we'll develop something like that at some point. But we also think that there's some other opportunities. And one of them is to look at any transition point in your disease or one's disease. For example, before you have metastases, you are pre-metastatic. And then when you develop metastases, you're at a different stage of disease, and your life expectancy and the treatment you're under going to go are quite dramatic. Is there a way to prevent that from happening? Or if you're on treatment and you're receiving treatment, we know that eventually, for most people with metastatic disease, their tumors will stop responding to therapy and they'll have progression. Can we look at that series of events, and prevent that progression from occurring? And that's what we've really been spending a lot of time focusing on. And again, the opportunity to think about a vaccine doing that is one that we're excited about. And here's an example which represents a lot of recent work. And this reflects the opportunity to treat women with hormone receptor positive or ER positive breast cancer, which occurs in the vast majority of women with breast cancer. Many women will go on anti-hormone therapy, tamoxifen, or an aromatase inhibitor, or some form of therapy that blocks estrogen. And what happens is that this can be quite effective and can lead to quite meaningful improvements in life. But for women with metastatic disease, there's an eventual escape of control, and the disease will progress. And it turns out that the genetic features of progression turn out to be somewhat predictable. We can identify changes in the email address or changes in the Social Security number of those tumors that progress versus those that are still responsive. So the idea we had was, could we immunize women who are starting on endocrine therapy and create a system in which their bodies would fight their tumors as well as the anti-estrogen therapy, and in fact create a super armed approach to prevent progression. And this is a cartoon that really shows, again, a model in which a tumor cell might initially be responsive to anti-estrogen therapy. Over time, the genetic changes occur in the tumor, and the tumors will eventually come back and recur. And again, usually this is a very difficult time for patients because there's not many treatment options at this point that will prolong their life. And the hope would be that if we developed a vaccine that would prevent the resistant tumors from coming out, would that be almost like a prevention strategy? So it turns out that in the laboratory, we can take a vaccine like the estrogen receptor vaccine, really target the mutations found in estrogen receptors that cause resistance to therapy, and in fact, we can prevent animals from developing recurrence or resistance to anti-estrogen therapy. Again, we're quite pleased with this, and this is very early, but we have actually opened up a clinical trial just in the last few weeks, in which we are immunizing women that have hormone receptor positive tumors with the idea that they will be triggered to fight any tumors that are trying to mutate and trying to overcome the anti-estrogen therapy that's been prescribed for them. So the idea that the immune therapy not only can be used in people with advanced disease and perhaps combined with immune checkpoint inhibitors, but there might be some cancer vaccines that will prevent the inflection points or progression of certain forms of disease. And then, of course, as we learn more and as we improve, our strategies, can we, take people who are at high risk or have a propensity, perhaps with a pre-malignant lesion, to be at risk for developing breast cancer, and can we minimize their chances of developing breast cancer through a series of what we think are low toxicity, low cost interventions that, again, we can apply to folks and people to prevent breast cancer, which again would be our aspirational goal through a series of maybe smaller steps like we've talked about. So I want my last slide really is just to highlight the fact that all of these activities are done as a real team. This is a set of investigators that include nurses as well as research scientists and staff and so forth. But the real partnership is with patients and communities and folks who are joining together to really try to make a difference. There's no question there's a whole range of activities and excellence and passion in trying to address breast cancer. And certainly we're thrilled to be able to share a little bit of our story with you. And again, I'm so pleased to be here and would be happy to answer any questions or seek your insight or thoughts on what we're doing. So thanks, Lynn.
Thank you. Excellent talk. And I think Leslie is going to pull up questions.
Yes, I am. In the chat, I have a few questions for you. Okay, Dr. Lyerly, one of our survivors is asking, does insurance cover this vaccine? And I'm assuming since it's in a clinical trial, is it provided free by chance?
So that's a great question. So the clinical trials that we conduct typically have a variety of components in them. For example, they typically, at the minimum, have standard of care therapy. So we would never, give somebody a piece of rock candy or, something that's experimental and see what happens. So the clinical trials of today really are, you're getting the best standard of care therapy plus something experimental. So the plus part, the experimental part, that's all provided through research grants. There's never a charge to an individual or anything like that. But oftentimes, since they're done in concert with standard of care, the usual and customary charges for that type of care tend to be charged and so forth. So there's the balancing act for that. So it's very rare to have somebody participate in a clinical study that's completely experimental. I've not seen that too often, but I guess it would be possible. But our studies tend to be, you're getting standard of care plus something experimental.
Okay, and another survivor has asked, how often is the vaccine needed? Is it given one time or every several years, or how often is it needed?
Sure, great question. We don't really know. What we do know is that we think that the vaccines induce an immune response, and what we have done is try to immunize people, using kind of a boosting approach, perhaps immunizing them every few weeks for 2 or 3 vaccines, and then the idea would be, after 6 months or a year, thinking about a boost. Since we don't have any data yet on some of these vaccines, we don't have the boosting strategies up, but we are asking people if we can measure their immune response in their blood, and the idea would be if we see their immune response increase in response to the vaccine, and we see a benefit from that, and then we see the immune response drop off, we can ask the FDA if it would be okay to sort of continue to immunize. As you might imagine, the FDA oversees all of these research studies, and they ask us to look, very carefully at any side effects or any toxicities and so forth. So we do have to follow folks. And again, we've not seen any toxicities or side effects, but that's why we can't say we would know what we would do right now, because if we guessed correctly that there wouldn't be any side effects, it would probably be something we might boost every 6 months to a year. But we would want to check on that first to make sure we wouldn't put anybody in harm's way.
Okay. Another survivor is asking, she has completed her 5 years of Arimidex and has no sign of recurrence. Would she be a candidate for the study? She was HER2 positive, had a mastectomy, but no lymph nodes spread, and it was DCIS stage 1.
Mm-hmm. Well, again, I think that's a great question. I think an individual that has stage 1 DCIS and is 5 years out and has had the type of treatment that she's had, probably the kind of projected outcome or the risk of recurrence for that individual would be quite low. And so I think there's always a pro and con of any kind of experimental therapy. If you have really an outstanding, very low rate of recurrence, or, of course, a recurrence would probably occur before, death and so forth. So I do think it would be possible, but I would probably suggest to that individual that weighing the pros and cons, just a conventional therapy and quality issues regarding lifestyle and so forth might be, an attractive strategy. And the reason I say that is because any form of experimental therapy is not only a promising upside, there's also the potential for a downside that you have to always consider. It's never zero. And so if something provides, an extra 3 months of life and it has absolutely guaranteed no downside, of course you would take that on. You would want that for yourself or somebody in your family. But if there was some potential to improve your life expectancy 3 months or a year or 5 years, but there was some chance you had a serious side effect, then that's a different equation. And so for experimental therapies, we can't answer the side effect or adverse event question. So if you have an excellent chance of doing great, it's hard to improve on that. And then, so that's where the equation seems like it'd be more likely to tilt, not in your favor to try something experimental at that stage. So that's usually the way we try to talk to folks. Now, of course, everybody's perspective is different. We're not paternalistic at all, but we would just want to make sure that people could understand that balancing act when they made a decision.
Okay, we have another survivor who is asking for the trial. Did all 20 women have traditional treatment, which would include Herceptin and radiation, prior to the vaccine?
Right. So the women did, and they had surgery and radiation and chemotherapy and Herceptin therapy and so forth. So they all received the standard therapies. As we mentioned, these therapies that we're talking about, what's attractive about them or at least one of the things about them that I find is attractive, is that their toxicities are so low, at least from what we've seen and what we've experienced, that you can combine them with standard therapies, and that's not a problem. As you know, with many forms of chemotherapy, they have what we call additive toxicities. So if your white blood cell count goes low and you add another chemotherapy and it goes even lower and you get colitis or diarrhea or nausea or vomiting, or you have a neuropathy, all of those things, again, increasing the toxicities without really proving or having a real benefit are really tough to do. So these immune-based therapies tend to have a profile of toxicities that are very, very different, and that's why I think they've been used in combination. I would say the field is quite interested in immune-based therapies. I think there's probably over 1,000 clinical trials going on today in which immune-based therapies are used alone or in some combination. So it's certainly a dramatic shift, as I mentioned, over the past 5 to 7 years. And I always like to tell folks that in medical school, they tell you, half of what you learn will be wrong, and they just don't know which half. They can't tell you which half will be incorrect. And I think the idea that immunotherapy was going to work in cancer was one of those in which, I would say 95% of the oncologists, probably all of the doctors that you were treated by, excellent, outstanding physicians and so forth, but the 9 out of 10 of them would have thought that the immune-based therapies weren't ever going to work, and now they're seeing them emerge. So as you talk to your physician, I'm sure there'll be a range of reactions to these types of therapies.
We have about 3 or 4 other questions. The next one is, are you still okay on time, Dr. Lyerly?
I might take one and then turn my camera off, and then I'll have to pick up my the one I have to drive home with them because I have to be in the car with them. But I'll have to pick them up. But I can speak. But if I scream, it has nothing to do with your questions at all.
Okay. This next one is, a patient has had DCIS now for the 3rd time. This last one was after a mastectomy in 2008. She was told it was in her skin. The PET scan and the lymph nodes were all clear. She's just concerned and completely caught off guard with her latest diagnosis, and she's wondering if she would be a candidate.
Right, great question, and again, a very troubling, story about DCIS. Our research group actually has a lot of interest in early breast cancer and studying DCIS, and I think there's a lot of interest in trying to understand DCIS from that perspective. I will say that again, the typical prognosis for even with the recurrent DCIS tends to be as far as having a fatal outcome in the next 5 or 10 years, the odds would be very, very low for that to happen. So I think this form of therapy, would not offer an improvement in, for example, reducing their rate of risk of death and so forth. But certainly the idea of having a recurrent DCIS, that individual, if they had an interest in contacting us, we would love to hear from them and learn more about them. We do think that we have some insight and some research into different forms of DCIS and why some DCIS can be seen throughout the breast tissue, and other forms of DCIS are more focal and present, and you can cut them out and they don't come back. So we do have a research program on that. Lynn, we're sorry I didn't really talk about that activity, but certainly we'd happy to come back or speak to anybody individually if they have an interest in learning a little bit more about what the options they might have.
Yes, and we do have several patients that are indicating to me that they would love to talk to someone at Duke. I have actually taken a snapshot of the questions, and if it would be easier for us to just send these questions to you in the next day or so that you wouldn't have to answer them while you're driving, I'd be happy to do that.
Okay, well, it might be a little bit safer. It might be less unnerving for my son, so that's probably wise advice.
Okay.
I know there was one question, Dr. Lyerly, they were asking, is this offered anywhere in Charlotte, or are these Duke studies?
Well, that's a great question. So what we try to do is we do try to open the studies up and make sure that they would be available to individuals and other physicians and so forth. So we're very open to that. I tell you, with all the rules and regulations, it takes forever to do anything, and so by the time oftentimes we open the study up, the study is completed and so forth. But certainly any physicians or anybody who has an interest hearing more about it, that would be great. Currently, we're planning on opening the studies up in Houston, Texas, which is interesting. They have you might think, boy, in Houston, why would they ever need anything other than what they've already done? They have a very huge medical center there. But again, it's, as I mentioned before, kind of the innovation strategies, the immune-based therapies come from all over, and so there's a lot of interest. From a variety of sites and so forth. But again, we know that it's always troubling to have to travel and to go somewhere. But hopefully, it wouldn't be too far to get down to the Triangle area.
Well, thank you so much for joining us tonight. Again, we'll keep your questions and we will share your contact information as well, so that indeed, if there's somebody that wants to reach out and learn even more, they can do so. And we would love to have you back again. So I will be back in touch with you at some point and we'll do a different topic. So.
Well, thanks. And again, thanks to all of you for your participation and your insight and your thoughtful comments and so forth. It certainly is a primary motivation for all of us in our group to really think about, making a difference and really partnering with all of you and trying to find the most important questions, addressing those, and really trying to find solutions for them. So thanks so much for all of the work that you guys are doing, and look forward, Lynn, of catching up with you. And if I can come back, and Leslie, thanks so much for your thoughtful attention to all the arrangements and so forth.
Absolutely. Thank you, Dr. Lyerly. Keep up the great work.
Bye.
All right, then we'll share the information as we talked about, and if you've got particular questions that you really, want to send through us, you can, and we will send questions to him as well. So, and he will respond. So, thank you all so much for joining us. And
thank you. Great presentation.
Good.
Thank you, Kathy.
Glad. Thank you. Thank you.
Miss you guys.
Good night, everybody.
Thank you.
Bye.
Bye, Tammy. Great to see you. Everybody have a nice evening.
Thanks, Leslie.
Thank you.
Hey, Denise. Bye, Denise.
Bye.
Thanks again, everybody.